Uh, Good afternoon, everyone. Welcome to this webinar of acute kidney injury and critical care nephrology working group of African Association of Nephrology and Transplantation. I am Yasser Abdelhamid. I am a professor of nephrology and medicine in Cairo University in Egypt. And I would like to welcome you in this first webinar of the group that I have the honor and pleasure to be the current chair. This group is directed to orientation, or excuse me, the webinar is directed to start orientation of primary care physician program for AKI. And the aim of this, our program that is started by this webinar, is to help primary care physician to aid in the process of care of acute kidney injury patients in early stage of the to overcome the shortage that we all know in Africa regarding nephrologists number. So we are trying to help and these primary care physicians to aid us and help us in our care of the disease. This webinar will be in English, and I have the pleasure and honor to have two speakers and two lectures in this webinar. First speaker will be great Professor Sarah Diefneker from South Africa, and she will speak about acute kidney injury general look to primary care. Professor Sarah is an emeritus professor of medicine and former chair of graduate studies and research, academic head at Wits University, Johannesburg, South Africa. She was the previous president of South Africa Renal and Transplantation Societies, and the previous member of ISN Regional African Board, Educational Committee, ISN Council, and ISN, the National Society of Nephrology Executive Council, and KDIGO Executive Committee. Currently, we are honored to have Professor Sarala as one of the AFRAN Executive Committee member. She is the winner of ISN Roscoe Rofenson Award 2004 and Living Legend Award of University of KwaZulu-Natal 2003 from South Africa. She has more than 200 publications peer-reviewed and 18 book chapters published all through her academic journey. Professor Sarala, as I said, will speak about acute kidney injury, a general look for primary care. So please, Professor Sarala, start your talk, and we will be followed by the talk of Professor Vincent and come to the questions after the two lectures. Thank you so much.
Thank you very much, Professor Yasser, for that wonderful introduction. Good afternoon, colleagues. It's my pleasure to speak on this very important topic, which I'm afraid I'm not going to be able to do full justice to in the time allocated, because we just have 1 hour for the webinar. So I will cover the areas that I thought would be very pertinent for people at primary care medicine to deal with. And I'd be happy to cover any other areas in question time if necessary. I have no disclosures, and that is my outline of some of the topics that I'm going to be covering in this talk. And AKI it's important to know a few facts about AKI. A lot of people mention AKI the same as CCF. Both are not primary diagnoses or primary diseases. They are clinical and biochemical syndromes reflecting abrupt organ dysfunction. And as far as AKI is concerned, it's a heterogeneous syndrome with various causes and variable outcomes. And important to realize that people with chronic diseases, such as diabetes, chronic heart disease, when they have acute illnesses or any physiological disruptions, they may often suffer acute kidney injury. And important to realize that AKI can be very costly in terms of morbidity, mortality, as well as economically. But also, it's amenable to early detection and potential prevention. And I think that is where I would like to focus my talk today. As far as classifying AKI, we've had various classifications which have some minor differences. And in the interest of time, I'm not going to go through the details. We have the rifle, AKIN, and KDIGO. So I think it's important for us to use a specific classification. I personally have got accustomed to the KDIGO classification. And so there's a much of a muchness in the various classifications. We did a study looking at the prevalence of AKI in Africa, where we studied a huge cohort of pediatric and adults from 8 countries. And we found that mortality ranged from 13 to 80%, with a pool rate of just over 24%. And dialysis was required in up to 88%. And I think to realize that, and what we concluded was that there was significant underdiagnosis and underreporting of AKI in sub-Saharan Africa, and that poor access to health services and lack of facilities probably were major contributions to this. Another important thing to realize is that AKI is more frequent in older age groups, as you see from the study from the US through the various decades. And you could see at all time periods, it occurs more commonly in the older age groups, especially those over the age of 65. And looking at survival, again, the stages of AKI are important. So if you look at the survival in those who have no kidney dysfunction versus those with stage 1, and as you see, the ones with stage 3 AKI have the highest mortality rate. This study from the UK also showed the type of AKI determined the mortality. Those who had community-acquired acute kidney injury did much better, with a significantly lower mortality rate compared to those who had hospital-acquired AKI. And I think that can be quite self-evident in that generally hospital-acquired patients tend to have complex conditions, including surgery, multiple infections, etc. When we looked at the main cause of acute kidney injury in sub-Saharan Africa, infections were largely featured here. And when we look at the African context, common infections such as malaria, HIV, diarrheal, and other diseases. Nephrotoxins, also an important cause in Africa and elsewhere. And in both developed and developing countries, contrast media, very important, and Professor Vincent Boema is going to cover it, so I'm not going to say too much about it. And in our context, we always should ask about traditional herbal or over-the-counter medications. And then, of course, obstetric and surgical complications are very important as causes of AKI. Now, to look at it simplistically in the classification of pre-renal, renal, and post-renal, I think it's important to try and determine this, because then that determines how you should investigate and manage patients. Pre-renal is largely related to inadequate perfusion, and one should check the volume status and blood pressure. Seems simple, but in elderly patients, it's often not that easy to determine volume status. When we look at intrinsic renal causes, AKI may occur despite adequate perfusion and urinary excretion. And in this instance, one should, the urinalysis showing presence of proteinuria and blood may often give you a clue to the diagnosis. And of course, other tests, which I will discuss later, are important. And then post-renal causes, where there's blockage of outflow of urine, it's important to exclude this by looking at whether the bladder is distended. one might need to catheterize the patient, and very important is an urgent ultrasound to make sure to exclude the diagnosis of obstruction. And the sooner one relieves obstruction, the better the patient does. Now, often one needs to think about acute kidney injury as being a barometer that's associated with acute illness. So this program that the NHS has, Think Kidneys, is very useful one, and one could find it in the NHS website, which gives very practical advice for primary care physicians. So one has acutely unwell patient with tachycardia, fever, hypotension, inflammatory markers, urinary output decreasing, and one needs to consider the diagnosis of AKI. So prompt recognition and good management of AKI is important. And so one needs to have a strong index of suspicion in acutely unwell patients and consider the diagnosis of AKI to manage them properly. Now, looking at common causes in primary care, both pre-renal and post-renal are very important causes, accounting for more than 90% of all causes of AKI. It's important to bear in mind that kidney function requires adequate renal perfusion, and there may be many reasons for perfusion to be disturbed. And for instance, vasodilatation and hypotension due to sepsis, fluid loss from the extracellular volume compartment due to diarrheal and vomiting conditions, or bleeding, hypotension with acute heart failure. And then, of course, drugs used in this situation can actually precipitate, magnify AKI, and therefore drugs that affect the renin-angiotensin system, such as the ACE inhibitors or the angiotensin receptor blockers, may need to be stopped during this period. As we all know, kidney function requires adequate urinary drainage, and therefore the threshold for early kidney ultrasound is very important. And one needs to particularly consider this in men with enlarged prostates, or suspicion of renal calculi, or if there are pelvic or abdominal masses. And also one needs to consider it in women with cervical problems like cervical malignancy. And delays in relieving obstruction may magnify the problem of AKI. So one addresses these four common drivers: volume depletion, sepsis, drugs, obstruction. This will address the majority, over 90% of cases of acute kidney injury. Intrinsic kidney disease is less common, but it's important not to miss, because treatment can also reverse this and restore patients' kidney functions to normal. So as I mentioned, intrinsic renal disease is less common, up to about 5% of cases. And it's important not to miss it, because patients will benefit from early renal referral. And generally, this is a group of disorders reflecting toxin or immune-mediated kidney damage. And the urine dipsticks is often the key to diagnosis. So the simple dipsticks showing proteinuria with or without blood on dipsticks should raise the suspicion of intrinsic kidney disease. But some conditions such as myeloma and tubular interstitial nephritis can be present with the normal urinary dipsticks. So one can consider intrinsic renal disease as cause of AKI if there's no common or obvious cause for AKI, such as sepsis or volume depletion, etc. And if the urine dipsticks is suggestive, and there are clinical features of a nephritic or systemic illness. And this slide shows the clinical context where one should have suspicion For instance, patients with rash, arthralgia, arthritis, hemoptysis, crush injuries, hemolysis, severe hypertension, vascular surgery or vascular interventions such as contrast procedures, recent chemotherapy, hypercalcemia, and if one has started a new drug recently. And this column shows you the various potential diagnoses, and one is directed to appropriate screening tests according to the clinical scenario to try and make an appropriate diagnosis. So when we're planning to manage AKI, one needs to think various things. Firstly, the cause. One needs to review the patient within the clinical context. History, when one is evaluating patients for kidney disease, the history and chart review is critical because that often gives you the diagnosis without one having to resort to too many expensive and demanding tests, which can then be done in a directed manner. So when one thinks of an acute illness like sepsis or hypotension, that would suggest appropriate cause there. Positive urinalysis in the absence of urinary tract infection. There are multi-system symptoms. One needs to think about intrinsic disease. And then obstruction needs to be considered if there's a palpable bladder, or one needs to consider an urgent ultrasound. And it's always important to think what drugs the patient is taking. And when one looks at a patient with acute kidney injury, one needs to take a detailed drug history, both prescribed and over-the-counter drugs, because one of these may be the offending drug. For instance, non-steroidal anti-inflammatories may be purchased over-the-counter, not something that is necessarily prescribed. So therefore, one needs to think about that, whether this is causing both acute or in some cases chronic kidney damage. And then if the blood pressure is low, one needs to look at what blood pressure medication is present. And if dehydrated, one needs to stop the diuretics and the blood pressure drugs in this situation. And then to think about various drugs that could accumulate, such as diabetic medicines, digoxin, opiates, etc. Also, has there been a recent prescription of a new drug, for instance, in the last 2 weeks or so, that could cause tubular interstitial nephritis, such as antibiotics or non-steroidal anti-inflammatories or protein pump inhibitors, which are very, very commonly used. And then when one thinks about the patient's hydration status, one needs to tailor the fluid advice to the clinical context. And if the patient is hypovolemic, one needs to look at the blood pressure and urinary output. Can the patient ingest a lot of oral fluids, or intravenous fluids may be required, and fluid bolus to try and get the blood pressure up and the urine output. And if there's fluid overload, one needs to consider if there's a risk of pulmonary edema before pushing fluids, and whether the patient is passing urine, and whether one should try and give diuretics to try and induce a diuresis at this stage. And then one needs to think of when to review the patient. If the patient is acutely well and has stage 3 AKI, one needs to have very early review and admit the patient. If there's hyperkalemia and risk of pulmonary edema. So they suggest these timelines for stage 1 AKI, stage 2 and stage 3. So therefore, one needs to consider and investigate for acute kidney injury when the clinical scenario and risk factors are present. And if there's a baseline kidney function, it's important to compare the serum creatinine with the patient's baseline kidney function. And therefore, if one is using the various criteria to detect AKI, one can look at a rise in serum creatinine, by about 26 or more micromoles per liter from baseline within 48 hours, or a rise by 50% or more in 7 days. And urine output, which seems easy, but sometimes is the most difficult thing to do, is to see if the patient's urine output is dropping. And this is the formula one looks at, where if the urine less than 0.5 ml per kilogram body weight per hour for 6 consecutive hours in adults and 8 hours in children. What about the role of biomarkers? Biomarkers can be very important in making an early diagnosis, and they're also important in prognosticating recovery and death. But suffice to say that while these are very interesting and there's a lot of research on biomarkers, it has not yet reached the clinics where 118 biomarker measurements. So as mentioned, generally when one sees an elevated serum creatinine or blood urea nitrogen, it's generally at a late stage when there's cellular necrosis. At the stage of damage, at this stage, the kidney function is still most likely normal in the form of serum creatinine, and the urine output may still be preserved. And this is a stage when there may be ischemia, reperfusion damage, or other areas of toxicity, and the tubules are damaged, and that one could see that the cells, the tubular cells are damaged. And various biomarkers have been shown to be excreted in the urine in this stage. And biomarkers, as I've mentioned, have been reported to be to predict the risk of complications, non-recovery, mortality, and all these add to healthcare costs. There are various biomarkers, stress or damage biomarkers, where one finds them in septic or hypovolemic post-surgery, AKI, and functional biomarkers when acute kidney injury stages 1 to 3 are present, and one could find them in various causes of AKI. But as mentioned, currently they still are in research settings. So looking at the timelines for recovery, one could see that there are various things that could happen to patients with acute kidney injury: full recovery, partial recovery with acute on chronic kidney disease, or conversion of acute to chronic kidney disease, or progression to end-stage kidney disease. So it's important, the importance of recovery in the trajectory of AKI in critical illness is important. And patients who recovered from AKI within 7 days and did not have any relapse had a 1-year survival of 90% or more. Those who had a relapse after early recovery had a 5-fold higher risk of death at 1 year. And the ones who had no recovery had the worst prognosis, with approximately 40% survival at 1 year. The other thing to consider is, why is there chronic damage in some patients with acute kidney injury? One generally thinks about acute tubular damage, which undergoes regeneration and repair, and then the patient fully recovers functionally, biochemically, etc. But then in some instances, this process is maladaptive. There's a outpouring of inflammatory cells, macrophage, cytokines into the kidney substance. And these set up a milieu where there's fibrosis. So instead of non-fibrotic healing, fibrosis supervenes with extracellular matrix deposition and collagen and fibronectin being produced. And this leads on to chronic damage and organ dysfunction. And when one looks at this conceptual modeling of AKI, acute kidney disease, and chronic kidney disease, so when one diagnoses AKI, the duration is within 7 days, whereas acute kidney disease, less than 3 months, and anything more than 3 months, one would diagnose chronic kidney disease. And generally, the criteria one could see, the criteria for AKI, as we discussed previously, was a criteria for acute kidney disease where the GFR is less than, where there is AKI or a GFR less than 60 mLs per minute, or decrease in GFR by more than 35%, or there's an increase in serum creatinine by more than 50%. And there may be markers of kidney damage, such as albuminuria, hematuria, pyuria. I won't go into chronic kidney disease, except to say that renal dysfunction must be present for more than 3 months with a GFR of less than 60 mLs per minute. And often there's a marker of kidney damage present, with albuminuria being the most common. Now, AKI, while one thinks about this simplistically as only affecting the kidney, it is actually a multi-system condition. And when various organs are studied, one could see that there are cytokines, growth factors, etc., affecting various organs. For instance, the heart. It's been shown that there's an increase in interleukin-1, 6, TNF-alpha with neutrophil infiltration, resulting in decreased fractional shortening and myocyte apoptosis. And again, in the brain, similarly, increased permeability and encephalopathy. Liver, similarly, increase in cytokines with transaminitis, neutrophil infiltration, and periportal necrosis and oxidative stress. With the lungs, one could find increased vascular permeability and sodium channels downregulated with pulmonary edema, alveolar hemorrhage. And as far as the gastrointestinal system goes, there's also increased vascular permeability with increased 17A present, neutrophil infiltration, and villus cell, endothelial cell apoptosis and necrosis. And this often presents clinically as a uremic encephalopathy and with lung involvement, volume overload, and when the heart is affected, volume overload and increased preload with myocardial depression. In the gut with nausea, vomiting, and malnutrition. You mentioned the liver becomes congested and the transaminases are elevated, and there may be cholestasis. As far as the bone marrow goes, there's immune dysfunction with anemia and thrombocytopenia. So what are the prevention strategies that one should think about? KDIGO original guidelines in 2012 still stand, though there have been an updating of some of the guidelines in 2019. And currently, KDIGO is looking at the AKI guidelines. So what about the use of diuretics, which is something that we like to use in patients with kidney disease? So the evidence shows that diuretics do not prevent AKI, grade 1B, which is very strong evidence. And then diuretics are not recommended to treat AKI except in the management of fluid overload. So one should try and use the diuretic to try and induce diuresis, to try and offload the volume. But if this is not successful, then one should perhaps restrict fluids and not continue with diuretics, because that could add to drug toxicity. And then all these drugs mentioned, which previously were the subject of many research papers, like low-dose dopamine, felodipine, phenoldiprem, atrial natriuretic peptide, IGF. These have all been shown that they're not effective in preventing or treating AKI. Just in neonates, a single dose of theophylline may be important in severe perinatal asphyxia. And looking at ACE inhibitors, when the patient is stable, is recovered from acute illness, volumes restored, blood pressure is restored, kidney function restored, then one could gradually reinstitute the ACE inhibitor or angiotensin receptor blocker. One's got to look at the clinical context. Why were these drugs prescribed? Was the presence of heart failure, diabetes, or chronic kidney disease? And therefore, these drugs are beneficial for the patient overall, and therefore there should be a reduced threshold to resume these drugs. So one needs to restart the drug if there's a strong indication, but important to review the patient and the bloods in 1 to 2 weeks. So generally, if the initial creatinine rise is less than 30%, one could cautiously continue. But if the rise is more than 30% and progressive, one needs to stop the drug and consider renal opinion. And if the indication is heart failure, one needs to consult a cardiologist for this. And then looking at other potentially nephrotoxic drugs like aminoglycosides and amphotericin, one should try and not use these drugs unless there are no suitable, less nephrotoxic alternatives possible. And in patients with normal kidney function in steady state, aminoglycosides should be used as a single daily dose rather than multiple dose regimens. I'm not going to talk about contrast nephropathy at all. I'll leave this to Vincent. I'm sure we'll talk about the importance of fluid, type of contrast, and dose of contrast. So when one sees a patient with acute kidney injury, it's important to consult the nephrologist, discuss AKI management as soon as possible, and within 24 hours if one of the following is possible, especially if there's a potential diagnosis such as vasculitis or glomerulonephritis, or there's AKI with no clear cause, and there's inadequate treatment response or complications with AKI, or if AKI is severe, especially stage 3, and the eGFR is less than 30 mLs per minute. And also patients with kidney transplant who have AKI and CKD stage 4 or 5. These should be urgently referred to the nephrologist. And one should refer adults, children, and young adults immediately for kidney replacement therapy if any of the following are not responding to medical treatment, such as hyperkalemia, metabolic acidosis, symptoms or complications of uremia, such as pericarditis and encephalopathy, because these are urgent indications for dialysis, and if there's presence of fluid overload and pulmonary edema. So in conclusion, it's important to realize that strategies to prevent AKI are critical and should be the focus in primary health care. And therefore, it's important to alert the healthcare worker and populations of the risks for AKI and the need for early detection and prevention. It's important to bear in mind high-risk populations with AKI would progress to CKD, such as older age, those who start off with lower baseline kidney function, where there's a need for dialysis, or very severe AKI is present, patients with low serum albumin, and those with heart disease, diabetes, etc. And most important for everybody is that patients should be evaluated at 3 months post-AKI to assess kidney status, to assess whether the patient has recovered fully or whether there's a need for long-term surveillance. So while this is an old slide and was the subject of World Kidney Day more than 10 years ago, I think this is still valid and important now, that kidneys are important for one's life and one needs to stop acute kidney injury. Thank you very much for your attention.
Thank you, Professor Sarala, for this highly comprehensive, elegant lecture, summarizing AKI, especially for primary care physician in a very smart way. In summary, you addressed most of nearly all of the aspects of AKI being a costly with a condition with a high morbidity and mortality. The etiologies of AKI being hospital or acquired, causes, and especially what are the community-acquired causes, including especially drugs and dehydration. Early prevention is very, very, very important, and early detection is the way for early prevention, and this depends mainly in clinical strategies, how to identify patients with acute kidney injury and how to diagnose them clinically in order to have an investigation-directed approach, case-directed approach for the investigations, not to do unnecessary investigations. Also, thank you for addressing the importance of renal disease in spite of being less than 5%. These are important, can be directed with a specific therapy. Detailed drug history is important, as Professor Sarah Aldiv said, especially antibiotics, non-steroidals. And thanks again for stressing on the point of how to use ACE and RAS inhibitors, renin-angiotensin system inhibitors, which are now commonly used for many of the cardiological and internal medicine conditions. Also, the prognosis, which is related mainly to the recovery and the importance to assess recovery after 3 months and how degree of recovery, which is important for the prognosis, and also the biomarkers, how to use biomarkers, what are the available biomarkers, and also for advanced diagnosis. How to prevent measures according to guidelines, including fluid therapy, including role of diuretics, and the drugs, especially again, ACE inhibitors and RAS inhibitors. Thanks for specifically for a specific slide for referral criteria. When to refer acute kidney injury from primary care to special nephrologists, specialists, or consultant. And I think this what primary care should care about, when to stop caring for the patient and go to a specialist. Thank you, and we'll go to questions after Professor Vincent's lecture. Second lecture will be by my friend and colleague in acute kidney injury group, Professor Vincent Boimov. He is the Associate Professor of Medicine at University of Ghana, Medical School, and a consultant nephrologist at Carleton Teaching Hospital in Ghana. He is the head of nephrology unit in the Department of Medicine and Therapeutics. He is the fellow of College of Medicine South Africa, West African College of Physicians, and College of Physicians and Surgeons, and of course, fellow of International Society of Nephrology. Currently, Professor Vincent is the Deputy Chair of Renal Registry Committee of African Association of Nephrology. He has over than 60 publications in peer-reviewed journals published in all aspects of nephrology. He will speak about contrast-induced acute kidney injury, and I'm expecting a very interesting lecture. So please, Professor Vincent, start your lecture.
Thank you, Professor. Yes, I thank you, Prof. Naika, for a comprehensive lecture. You have touched on most of the things already, particularly regarding management of acute kidney injury. So in this presentation, I'll emphasize more on the prevention of contrast-induced AKI. So I'll be talking about contrast-induced acute kidney injury following what Prof. Naika talked about earlier on. I have no disclosures either, and I'll follow this outline. So contrast-induced nephropathy, or what we call contrast-induced AKI, is potentially a reversible type of acute kidney injury and can occur soon after contrast media administration and could also lead to immediate renal toxicity. However, most of the time it's transient and also reversible and may not have any significant clinical consequences or results. By way of definition, an absolute increase in serum creatinine of more than 0.5 milligram per deciliter or 25% relative increase in serum creatinine from baseline could indicate that somebody may be developing an injury from contrast procedure, and that should occur within 48 to 72 hours after exposure, and usually the creatinine tends to peak within 3 to 5 days after exposure. These should be in the absence of other causes of acute kidney injury, as outlined earlier by Prof. Naika. The incidence of these contrast-induced acute kidney injury depends on many factors, including the types of contrast that is being used, high osmolar, isosmolar or low osmolar contrast, which may have different incidences or may have different degrees of injury relating to the kidney. Those are the contrasts, the volume of contrast, the type of procedures may all be influenced the incidence of the procedure. For instance, some types of contrast procedures may require larger volumes, etc. And the risk factors very important, particularly those with CKD and diabetes may have higher incidences of contrast-induced AKI compared to other groups. This was a study which looked at early shift to predict contrast-induced nephropathy, and then noticed a slight shift in creatinine or increments in creatinine between 5 to 10% compared to baseline after 12 hours of angioplasty may produce contrast-associated AKI. And they also noticed that a 5% increase in the value of the creatinine would have a sensitivity of about 75% and specificity of about 72% in predicting early AKI from contrast-induced nephropathy. And this is thought to correlate very well with impairment of kidney function at 30 days after the contrast procedure, with sensitivity of about 87% and a specificity of about 70%. So largely, contrast-induced AKI is the third most common cause of new AKI in hospitalized patients after renal perfusion injuries and also nephrotoxic medications, which are the leading causes. And the incidence is around 11%, but could be as high as 50% in patients with underlying chronic kidney disease or diabetes. And some studies quoted as high as 20% based on the underlying risk factors that may be predisposing patients to contrast-induced nephropathy. By way of mechanism, we could summarize this into generation of free radicals causing free radical injury, osmotic nephrosis, and vasoconstriction. So when you are exposed to contrast agent, you have either nephrotoxic effect or disturbances in renal blood flow. And the nephrotoxic effect could be increasing viscosity or increased viscosity of the contrast in the tubules, which can block the tubules and cause tubular injury. Also, there could be production of damage to the epithelium from the generation of free radicals, which can cause production of pro-inflammatory mediators, which can cause tubular injury with loss of tubular polarity and result in apoptosis and necrosis. Again, sloughed off material from the denuded tubular epithelium can further cause tubular obstruction and cause injury. Now, when that happens with damage to the proximal convoluted tubules, there is increased delivery of solute and fluid to the distal part of the nephron, which can stimulate tubular-glomerular feedback. And these can, again, also cause vasoconstriction, which can cause prolonged ischemia and result in renal function impairment or injury. For the disturbances in hemodynamics or disturbances in flow or blood flow, largely has been attributed to the increase in production of vasoconstrictors in the form of renin-angiotensin and endothelin, a decreased production of nitric oxide and then prostaglandin, which are vasodilators. And these would cause a net kind of vasoconstriction, which prolongs the ischemia and causes further renal function impairment. And this injury from these ischemic changes can further also stimulate tubular glomerular feedback due to increased distal delivery of solute and further again worsen the vasoconstriction and cause more injury. So it could sometimes actually become a vicious kind of cycle. With the increased viscosity of the contrast in the blood vessel, it increases the risk of microvascular thrombosis, which also can decrease flow, cause prolonged ischemia, and also further cause injury to the kidney. So here you have a normal tubular epithelium on my left, as you can see, but with the free radical injury and osmotic nephrosis in the proximal convoluted tubule, there's vacuolization of vacuolar changes in the proximal convoluted tubule, as you can see over here with edema. And actually in the tubule, you can see blockage and damage to the tubular epithelium. So it can result in ATN with damage to the tubules, as you can see over here in this diagram. There are risk factors that increases the risk of patients to contrast-induced nephropathy. There are patient-related risk factors, and there are also procedure-related risk factors. Commonly is the renal insufficiency or CKD, diabetes with or without CKD, which are the most important risk factors as the incidence of contrast-induced nephropathy is higher in this patient group compared to other people, other risk factors. But there are other risk factors by way of age, above 70 years, volume depletion, hypotension, low cardiac output, heart failure, other nephrotoxic agents, NSAIDs, ACE inhibitors, ARBs, etc., renal transplant, hypoalbuminemia, and also procedure-related factors mainly are due to multiple contrast injections within a period of 72 hours, intraarterial injection site, and high volume contrast, and also high osmolarity of the contrast media. These are known risk factors that can increase the risk of contrast-associated acute kidney injury. So this is a study which was done looking at long-term clinical impact of contrast-associated acute kidney injury following PCI, and they use correlate and consequences of contrast-associated acute kidney injury. We're looking at, correlate and consequences of contrast-associated AKI and on clinical outcomes in patients with or without pre-existing CKD. There was a prospective study, multi-center registry of more than 8,000 patients treated with more than one drug-eluting stent, meaning we have repeated contrast procedures. And the primary endpoint for this study was the 2-year rate of net adverse clinical event, that's a NACE, which was in the form of all-cause mortality, myocardial infarction, definite or probable stent thrombosis, or bleeding. This study also was able to come up with incidence rate for contrast-associated AKI, and out of more than 7,000 people whose data were available for analysis, 476, that's 6.5%, developed contrast-associated AKI. And from that, they were able to categorize their primary endpoint based on whether the person has CKD and contrast-associated AKI or not. So if you look at that group of the patients who do not have CKD and who did not develop contrast-associated AKI, the incidence of their primary outcome in the form of net adverse event, clinical events, net adverse clinical event was low. That is in the form of all-cause mortality, myocardial infarction, or stent thrombosis was low. But when you look at the one who has no CKD but yet develop a contrast-associated nephropathy, they have a higher rate of adverse event compared to the patients who have no contrast-induced AKI. Again, when you compare this to patients who have CKD but did not develop contrast-associated AKI, they still have a slightly higher incidence of the adverse events that they were looking for. But here you can see clearly that those who have background CKD and on top develop contrast-associated AKIs have higher rate of myocardial infarction, all-cause mortality, and also stent thrombosis or bleeding compared to all the other groups. So they concluded that AKI, which is the contrast-associated AKI, was common after contemporary PCI and was associated with an increased 2-year risk of NACE, which is a net adverse event, net adverse clinical event, which was higher in a 2-year period. And patients with pre-existing CKD were at particularly high risk of NACE after contrast-associated AKI. Other risk factors which I mentioned earlier on was the higher contrast media volume which increases the risk of contrast-induced nephropathy. And even low doses are not really free of risk. You can still develop AKI with doses as low as 100 mils can actually induce permanent renal failure and need for dialysis, especially in people who have a background CKD. So this study looked at various risk factors, and as you can see here in red, you can see that the most important risk factors that were observed from this study was the background renal dysfunction and diabetes, with those who have severe forms of renal dysfunction having higher odds of developing contrast-associated nephropathy or contrast-induced AKI compared to those who have milder forms of kidney dysfunction. So any level of kidney dysfunction appears to be an important risk factor for contrast-associated nephropathy, including diabetes. There were other risk factors that were observed in this study, including age, 1 year increment in age. Each year increment in age will increase your risk of developing contrast and nephropathy, congestive heart failure, hypertension, low effective circulatory volume, myocardial infarction, use of intra-aortic balloon pump, and of course, osmolality and content of the contrast medium were all observed as risk factors for contrast-induced AKI. And there's also another study which looked at the incidence and outcomes of contrast-induced nephropathy after CT scan with CKD. And it shows that for those who have GFRs between 45 to 60, incidence was almost non-existent. And also for those who have GFRs between 30 to 45, they have a higher risk of developing contrast-induced AKI compared to those who have higher forms of GFR. In fact, this is even worse for those who have diabetes and renal insufficiency, who have higher risk of developing contrast-associated nephropathy. And more so, if your GFR is much lower, less than 30, the risk is even higher. So if you look at this in the context of heart failure vis-a-vis using the left ventricular ejection fraction, for those who have creatinine clearance higher than 60 and ejection fraction more than 40, the incidence of contrast-induced AKI is about 11.6%, but when the GFR is lower than 60, that increases to 17.5%. That is still with EF or ejection fraction of more than 40. When you compare these to those who have creatinine clearance of more than 60, but yet has ejection fraction of 40 or less, they have even higher incidence of contrast-induced AKI, telling you a heart failure or heart forward flow or systolic dysfunction is probably a very important risk factor for development of contrast-induced nephropathy, perhaps due to poor perfusion issues, which may increase the risk of this form of AKI. Those who have both low creatinine clearance, less than 60, and ejection fraction of less than 40 have even much higher incidence or risk of developing contrast-induced nephropathy. So heart failure turns out to be a very important risk factor for developing contrast-induced nephropathy. So looking at assessment of contrast-associated AKI risk scores, there was a consensus working panel in 2006, which came out with these criteria of looking or determining who is at risk of developing AKI based on creatinine cutoff values. So those with creatinine at baseline of more than 1.3 milligrams per deciliter or 115 micromole per liter in men, or if the creatinine at baseline is more than 1 milligram in women, then maybe they are likely or at risk of developing a contrast-induced nephropathy. And then in 2009, to define what a true contrast-associated AKI is, these authors came out with to say that the person must have at least a baseline creatinine of more than 1.8 milligram per deciliter or GFR less than 45 for us to say that, okay, the person may be having contrast-associated AKI. There are various ways of using risk scores to assess the risk of developing contrast-induced nephropathy, and this is one of them. This is old, but nowadays there are apps online on your phones that you can use actually to assess this kind of risk. And they look at various items, including systolic blood pressure of less than 80, or somebody who is on inotropes, and use of intra-aortic balloon pump, heart failure, class 3 or 4, age of more than 75, hematocrit of less than 39% or less than 36% for women, diabetes, volume of contrast, and then serum creatinine and GFR criteria, and they are scored differently. And for those with GFRs less than categories are also scored. Various GFR categories are also scored differently based on the risk. And with a total score of, say, less than 5, your incidence of contrast-induced nephropathy is about 7.5, and the need for dialysis is much less. But if your risk increases to between 6 to 10, your incident risk is mostly about 14, and then your need for dialysis is about 0.12. Again, if the risk is higher, this score is higher, then your chances of developing or risk of developing is also much higher. But these scores, like I said, now we have electronic forms which are available. There are some of the electronic links that can be used to assess or calculate these scores that will help you assess the risk of developing or having contrast-induced nephropathy. Like I said earlier on, Prof has already talked a lot of management of AKI, so I'm going to talk about prevention of contrast-induced nephropathy more of as time will not allow us to go into much more details. So this again is another kind of randomized prospective trial assess the role of cell line on the development of contrast nephropathy, and there's a prospective evaluation of the role of deliberate saline hydration in patients undergoing non-emergency cardiac catheterization. And it involved 53 randomized patients who were randomized into 2 groups. The first group, 27 people, received normal saline for 24 hours at a rate of 1 ml per kilogram per hour, 12 hours prior to scheduled cardiac catheterization. And group 2 were made to have unrestricted oral fluid intake. And the conclusion from this study was that deliberate saline hydration decreased the incidence of contrast-associated nephropathy compared to oral. So again, this is another study which looked at prevention of contrast media associated nephropathy, randomized comparison of 2 hydration regimen. Here they use isotonic hydration, and then also half isotonic hydration. That was found that isotonic hydration is superior to the half isotonic hydration in prevention of contrast media nephropathy. These are various forms of contrast. The high osmolar contrast, high osmolarity of more than 1,005, is usually ionic and monomer, and also low contrast, more molecular contrast between 600 to 100,000. It could be ionic or non-ionic, usually dimer, have ioxalate, and also the non-ionic one, monomer, could be iohexol, iopamidol, iovexol, among others, etc. But the preferred one, which is the isoosmotic one, is a non-ionic one, which is dimer, and commonly the iodiazanol. And studies by Hendrik et al. Showed the benefit of iodiazanol being superior to a low molecular weight contrast. And of course, from studies, low molecular weight contrast is also superior to the high molecular weight contrast in the prevention or decreased incidence of contrast-induced nephropathy. So this was another study, which actually in the background to this particular study was actually looking at all the other studies that were done so far, looking at contrast-induced nephropathy and also the preventive methods that were used. So they actually were able to search for almost 529 papers, which were so far done in this field. And out of this, they filtered them down to clinical trials, and they were able to get about 150 clinical trials, but those which were randomized properly were just about 3 papers, and both of all these 3 papers actually showed that there is increased rate of contrast-induced nephropathy based on the risk factors, and also they were able to say that saline hydration was superior in the decreasing the incidence of contrast-induced nephropathy. However, this group of authors thought that this was not a representative data for guidelines. So they came out with this study design, which is a prospective randomized phase 3 parallel group open label non-inferiority trial. And they chose patients at risk of contrast-induced nephropathy according to current guidelines. And patients selected had a GFR of between 30 to 59, were aged 18 years and older. Those with GFR less than 30 were excluded from this study. And these patients those are patients who are undergoing an elective procedure requiring iodinated contrast material administration. This study took place between June 17, 2014 and July 17, 2016. 630 consecutive patients were randomly assigned to receive either no prophylaxis at all or receive intravenous hydration. So about 332 were not on any prophylactic hydration, and about 328 were on prophylactic saline hydration. And they came out with this plot. So H plus is the hydration group, H minus at the top is the non-prophylactic hydration group. They did not receive any hydration, and they were compared diabetes, no diabetes at all. So for those who have diabetes in the hydration group compared to the non-hydration group, there was not much different. The difference was not significant. And then those who non-diabetic group as well, again, the difference was not that much. For those with GFR less than 45 plus those with GFR more than 45, again, the differences were not that much. Those who have contrast administration, IV, intraarterial IV administration, again, the differences observed were not that much. And then also intervention, those who have interventional procedures within the hospital, the differences were not that much. Overall, the incidence of contrast-induced AKI in the hydration group and non-hydration group were comparable and similar. And you can see that none of these effects really crossed their so-called non-inferiority lines. So either treatment regimen was not inferior to the other in terms of prevention or decreasing the rate or incidence of contrast-induced nephropathy. So the incidence of contrast-induced nephropathy recorded by them was 2.6 to 2.7% compared to previous literature where it could range from 0 to almost 50% depending on the underlying risk factors. And from their study, no prophylaxis was not superior to intravenous hydration. They also assessed cost effectiveness and said that for the no prophylaxis group was more cost effective in compared to the prophylactic group. And for them, all the interaction p-values were not consistent, suggesting a consistency of all effect at all the various levels I showed you earlier on, from diabetes, no diabetes, GFR, all the levels. There was consistency showing that proving that actually what they are proving consistency in terms of their findings across all the subgroups. So intravenous versus intra-arterial contrast administration, diabetes versus no diabetes, there was no much difference, and the p-values were consistent at all the levels. Low GFR versus no GFR above 40, again, there was no much difference, but rather there was complication of IV administration, about 228 people who were hydrated. And so they thought about all this and said, okay, complications, cost effectiveness, and then the fact that they didn't show any effect, did not think that there's a need for prophylactic intravenous hydration might not be necessary in patients with GFR, which at least is above 29 or 30. This is again another method which tried to use a different method to see if they could also improve or decrease the incidence of AKI. The randomized parallel groups comparator control was a controlled kind of single blind phase 3 trial. And they look at efficacy of new fluid protocol based on left ventricular end diastolic pressure for prevention of contrast-induced AKI in patients undergoing cardiac catheterization. And they came out to say, based on that, the left ventricular end diastolic pressure-guided fluid administration seems to be safe and effective in preventing contrast-induced AKI in patients undergoing cardiac catheterization. This study looked at the benefit of N-acetylcysteine and bicarbonate, but the differences were not, there was no clear differences compared to sodium bicarbonate, sodium chloride administration, and then sodium bicarbonate administration, also N-acetylcysteine, all compared to placebo. There was no difference at 90 days in terms of prevention of contrast-associated nephropathy or death from AKI, or need for dialysis as well. So there was no clear-cut benefit for bicarbonate and acetylcysteine in the PRESERVE trial. And this was another one which looked at the use of statins. And here they use atorvastatin 80 milligrams within 24 hours before contrast plus placebo plus bicarbonate and N-acetylcysteine, all patients. And they found out that in the control group, the incidence of contrast-induced AKI was as much as 17.8% and about 4.5% in the atorvastatin group. So there is some possible degree of saying atorvastatin could decrease the risk, or statins in general could decrease the risk of contrast-induced nephropathy, but I think this is still probably experimental. So looking at the KDIGO recommendation, the risk factors are reduced GFR, diabetes, reduced intravascular volume, concomitant nephrotoxic agents, NSAIDs, among others, high osmolar contrast agent, large volume contrast, serial contrast procedures, and intraarterial contrast seems to be prominent among all the risk factors that increase the risk of contrast associated AKI. So the recommendation is to use low volume and isoosmolar contrast, use minimal contrast, and stop nephrotoxic drugs 48 hours prior to patients with GFR less than 30. Consider withholding a RAS blockade or ARBs 48 hours prior to CT scan and restart later. Avoid dehydration, make sure the patients are well hydrated. There's no benefit of N-acetylcysteine, dopamine, dopamine, etc., and furosemide. Actually, furosemide may be harmful in this patient, so it's not recommended. And you can continue metformin. So there's some papers which actually showed that with GFR less than 30, there's a high risk of lactic acidosis high when these patients are exposed to contrast, but that study was also not conclusive and did not find that to be true. So you can continue metformin, especially if the GFR is less than is more than 30. So from the KDIGO 2012 recommendation, they said they recommend volume expansion using isotonic chloride or sodium bicarbonate solution, because some studies have shown some mild to moderate effect of reducing the incidence of contrast-associated AKI using bicarbonate rather than other agent. And then they also recommend not to use oral fluid, like I showed you in the one of the studies. Oral fluid was not beneficial, but IV saline hydration was beneficial. So oral fluids are not recommended for hydration before and after contrast procedures. Use the lowest possible dose of contrast, which is also recommended, but it's not graded. And we recommend the use of isoosmolar or low osmolar iodinated contrast media rather than a high osmolar contrast media, which is actually grade B, 1B. And consider alternative imaging methods where possible, which are also not graded. But in terms of the fluid administration, most studies suggest that fluid should be started at least 1 hour before and continued 3 to 6 hours after contrast media administration. A good urine output of, say, 150 mils per hour in the 6 hours after the radiological procedure has been associated with reduced rates of AKI. In order to achieve the urine flow of at least 150 mils, you need to be administering at least between 1 to 1.5 mil per kilogram per hour of IV fluid, and to achieve that for at least 3 to 12 hours before and 6 to 12 hours after the procedure, in order to decrease the incidence of contrast-induced nephropathy. So in conclusion, though the current evidence is not that robust in terms of the effect of contrast on the kidney, there's still some evidence showing there could be some injury. So there's a need for us to be prudent in coming out with evidence-based approaches that can prevent contrast-induced nephropathy based on risk profiling the patient, especially for patients who have underlying CKD diabetes, among others, like shown earlier on. There's a need for us to be proactive in terms of using all these evidence-based approaches to prevent contrast-induced nephropathy, mainly the IV hydration, and also considering using the lowest dose of contrast, using isosmolar and low osmolar contrast agents are preferred ways of preventing or decreasing the incidence of contrast-induced nephropathy. Like I said earlier on, there are risk scores online that we can use to actually assess the risk of development of contrast-associated nephropathy. And thank you very much for listening.
Thank you, Professor Koima, for this highly illustrative lecture about contrast-associated or contrast-induced acute kidney injury, what was called contrast-induced nephropathy, as you illustrated clearly. Thank you for illustrating for this condition being a very common condition. I think it is the second most common cause in the hospital, reaching up to from 11 to 50%. Stressing that it is a reversible one. Mostly it is a reversible one, and don't panic in spite of can cause acute kidney injury. What's the definition? You defined it clearly. How can we define, and what is the time interval for occurrence of contrast nephropathy timeline of start up to 72, and it can last up to, or can be expected up to 3 to 5 days. Instance mechanisms, mainly or role of free radicals in these mechanisms, and the risk factors. You illustrated clearly the point of risk factor, which is important, and I think this risk factor is of concern, major concern for primary care, including previous CKD and baseline and serum creatinine values. It's clearly illustrated that 1.3 is a cut point for males, or 115 micromole per liter, and 1 is a cut point for females, or 88.4 micromole per liter. Strange enough, you told us that a contrast dose is not that important as all can imagine. It is the type of contrast mainly which is important, and clear it was written in KDIGO, one P recommendation for type of contrast, while it was not graded for the dose of contrast, but of course you recommended to use the minimum use dose for contrast. And scales illustrating a link for calculation, how to prevent use of IV fluids, mainly hydration, and the role of drugs such as atorvastatin or N-acetylcysteine, which unfortunately of no major role in this prevention. Thank you for this highly comprehensive lecture, and we can come to the questions. Professor Neker, I have a question for you, please. Professor, yes?
Sorry, I was trying to unmute myself. Please go ahead.
Yes, you are unmuted. I have 2 questions for you. First, you said the etiology of community-acquired pneumonia, mainly drugs and common diseases such as malaria, especially in Africa, malaria or HIV or something, or sepsis, and obstetric causes we know. Do you think that, or have new data for with the change currently in the modern treatment regimens, for these causes to change, for some other causes to jump on the first, or for another cause to become the last, or something like this, or we will work with this current list for a long time?
Yes, in sub-Saharan Africa, the major causes seem to be infective, for community-acquired AKI, and especially where excuse me, where tropical infections of very high prevalence. So that certainly is a situation. And also in developing countries, while one looks at surgical and other causes, reaching more prominence. So I think for now, for Africa, it's still infective as number one cause.
Yes. Okay. Thank you for your answer. Please, for the attendees, post your questions on the chat, or you can raise your hands, please. My second question for you, Professor Nicker, is that you illustrated about a point about biomarker used in early diagnosis, which is, as we all know, early diagnosis is the most crucial in prevention of AKI. Or early detection is needed for the prevention of complications of AKI. What do you think, can you explain to us the position of cystatin C nowadays in this early diagnosis in comparison with the current marker, which is serum creatinine?
Yeah, I think cystatin C has a sort of bimodal importance. One is that it improves your efficacy of estimating GFR, because if you look at cystatin creatinine-based GFRs, that's important. And also, yes, as a biomarker, looking at blood and urine, it's also important. But my view on biomarkers is that it's only of importance or feasible when you're looking at patients, say, for instance, in an intensive care setting. You have somebody who's had, say, extensive surgery or this in cardiac surgery and has sort of multiple organ problems. And we know that once people have multiple organ problems, it's much easier to then do serial measurements of biomarkers, etc. Whereas in a non-intensive care setting, by the time you see the patient with AKI, they're usually advanced. So making an early diagnosis by measuring biomarkers, to me, is not useful, because by then your creatinine's up, your cystatin C is up, everything's elevated. So I think it can only be done in that hospital setting, and more so, not necessarily hospital setting alone, in the intensive care setting where patients are carefully monitored.
Okay. Only in hospital and the intensive care settings.
Mainly intensive. Yes.
Okay. Thank
but
you.
Very important when you're looking at prognosis, of course, because one can always measure these biomarkers at a later stage, and then one could see that.
Professor, it seems that Prof. Nicker is
not with us.
Yeah.
Okay, no problem. Till she will come. We have a question.
Yes.
May I know if routine renal function test is advisable for all patients? So a question for Professor Paima from Dr. Derek. Thank you for your wonderful presentation. May I know if routine renal function test is advisable for all patients post-IV contrast procedures? And if yes, how soon should it be done? The frequency of monitoring, if you recommend, Professor Paima?
So thank you very much for the question. I think from the definition, contrast-induced nephropathy occurs within 48 to 72 hours after contrast administration. So this will be a very good point where you can actually test for kidney dysfunction. In fact, should it be done routinely? I think that, number one, looking at how infrequent it is, looking at how the data is not conclusive, which if we have very high risk patients, especially those who have chronic kidney disease, diabetes, those who have heart failure, etc. For those people who are at high risk, it will be good to actually test for the kidney function at baseline and within 48 to 72 hours after the procedure to be sure whether the person is developing contrast-induced nephropathy or not. Of course, for inpatients is easier because once they are inpatients on the ward, you may be regularly checking their kidney function after these procedures, especially to be sure. Or maybe the urine output will be monitored on the ward, which will give you a sign that, okay, the kidney probably is having a problem, then you can check the kidney function. But for outpatients, I think that for very high risk group, even before the procedure, you should know what the GFR is, whether it is safe for the patient to have a contrast procedure in the first place. And number two, after the procedure within 48 to 72 hours, I think it will be ideal for you to check to be sure whether the person is still having a good kidney function or is now developing contrast-associated nephropathy.
Thank you.
There have been issues of whether we should use early biomarkers of acute kidney injury like the NGAL, cystatin C, or urine NGAL, and for contrast-induced nephropathy, because we know it's been said that after 2 hours after the contrast administration, NGAL can be raised and the levels in the blood can go up. But I think, just like Prof. Naika said earlier on, it's good for inpatients, it's good for prognosis. But is it cost effective to be using NGAL at this stage in the first place? So probably we have to go back to creatinine and use it anyway to estimate this. And cystatin C also goes up at least 8 hours after the contrast administration. But we should know that cystatin C in itself can actually be raised in other conditions like use of corticosteroid, neoplasias, among others. So it may not be very specific to use at this point. So yes, I think it's a good question. Thank you.
Thank you, and you illustrated it clearly. It is a matter of family of risk factors, and still we can depend on cystatin C. Professor Neker is back again. You can continue your comment regarding the biomarker use in acute kidney injury, role of biomarkers.
Yes.
You said that.
Yes. No, I concur with what Vincent has just said. Besides
Yes.
The feasibility, as I mentioned already, the timing for early diagnostic purposes, also the costs of these, because one has to do them serially, and other laboratories set up for this. So it can be a problematic issue. And therefore, the way I see it, it's more a research tool at the moment. But having said that, we do know that biomarkers can predict that, that very high biomarker levels can predict prolonged AKI or non-recovery or even mortality.
Okay. Thank you. Of course, it's a complex issue that needs thorough discussion, and
Yes.
I think separate session for after we with this program, we can make it a separate session for this discussion. My last question, basic question for Professor Poima, is about evidence-based. Do you recommend evidence-based use of a certain type of fluids in prevention of contrast-induced nephropathy?
Yes, Prof, I can hear you. So
Yes,
I think that from the evidence so far, it's all about volume expansion using isotonic saline, which expands the volume. And that has been shown to actually reduce the incidence of contrast-induced nephropathy. If you look at the KDIGO recommendation I flashed down earlier on, is if you achieve a urine output of, say, 150 ml per hour per kilogram per hour, you are likely to decrease the incidence of contrast-induced nephropathy. And I think that can be achieved by volume expansion. So if you're able to expand your volume well using saline, which we know stays in the vascular space to expand the volume, that will be also a good thing to actually reduce the incidence of contrast-induced nephropathy. But we know that there are other ways of reducing the incidence, which includes the amount of contrast we use. For instance, we can use low volumes, and then also the osmolality of the contrast itself, which we can also use low osmolar contrast or iso-osmolar contrast, which in turn will decrease the risk of developing contrast-induced nephropathy, particularly from generation of free radicals, which can cause damage to the tubules and etc. If you use low contrast and agents, maybe you will reduce that effect due to osmotic nephrosis. There were issues regarding using NAC because it's an antioxidant, and the mechanism they're looking at is whether NAC can decrease production of free radicals and therefore oxidative stress. But like you saw from the research work, there have not been any conclusive evidence to show that it is useful.
Okay, thank you. The most important is that volume expansion, and we can wait for the coming new KDIGO guidelines. They may specify some types, or may have more specification for this volume expansion in the coming version of KDIGO guidelines. Thank you, Professor Sarah, for this very highly comprehensive lecture and for responding for all the questions. Thank you, my dear friend, Professor Vincent Poimo, for your highly illustrative lecture and responding for the questions in a very simple way. And excuse me to close this session of African Association of Nephrology Primary Care AKI Primary Care Orientation Program webinar 1. Thank you so much, and excuse me to close. Thank you so much.
Thank you very much. Thanks for the invitation.
Thank you.
And goodbye.
Thank you. Goodbye.
Thank you. Thank you. Goodbye.
Bye.
Goodbye.